All right, today we have some jokes, compliments of Laffy Taffy. Okay, first one. Why did the bowling pin stop working? Why did the bowling pin stop working? Because they went on strike. Nicely done. Who said that? Nicely done. All right, how about this one? What gives a ghost the right to scare you? What gives a ghost the right to scare you? A haunting license. Haunting license. I think my kids are about the same level as these Laffy Taffy directors. Those are pretty good. All right. So today we're going to finish out where we started. We're covering the general properties of receptors. The general properties of receptors. And that was the homework that I asked you to do, is to compare and contrast. The general properties of receptors. If we back up to our homework assignment, maybe, there it is. What are some, let's do this right now together. Characteristics or examples of general senses. What are they? What are some examples and characteristics of general senses? And then where are they found? They're in the body, right? Some of you might laugh and say, well, that's a very generic answer. Yeah, but that's actually correct. They're actually found widespread throughout the body. Right? They're relatively complex or simple? Simple. General are rather simple. They're simple in structure. In some cases, it might be just a bare dendrite. So this is what you'd be filling in this box. Some examples. Touch, pressure, like Meissner's corpuscles. Stretch, heat, cold, pain. Some areas that you would see them throughout the body, like in the skin, in joints and muscles, in tendons, in the viscera. What about special senses? What are some characteristics of special senses? Smell. Okay, well, that's an example, but fine. What's another word for smell? Olfaction. Okay? So there are 5 special senses that we're going to get to. What are they? Smell, taste or gustation, vision, hearing, and equilibrium. Now, where are they located? They're only located in the head. They're not widespread throughout the body. And they're rather complex, as you're going to start to appreciate over the next couple of lectures. Okay? Good. Well, sounds like you guys are totally with me on that, because maybe you did the homework, and so that was a good thing. Now, if we start where we're supposed to be today, if my computer will catch up here momentarily. There we go. All right, if we look at our general properties, so we're looking at general properties of receptors, and we have 4. We have modality, location, intensity, and duration. This could be another homework assignment for you, is see if you can define each of these and give examples of what they mean. So, like, for example, the modality is the type of the stimulus. Is it sending a sensation? Yes. Whoa. That's a good song, Brett. I guess that's all right. Now, something's up with the computer. It's just got a mind of its own today. Okay. Before we broke through into that song, we were here. So If the sensation that it produces is vision, then its modality is in that category. The location is encoded very specifically by nerve fibers, and they go to certain locations within the brain. And we're going to see that. If it's a sensory input from a touch receptor in the hand, on the left hand, then obviously it's going to go to the somatosensory cortex on the right hemisphere. Okay, so we actually have very specific locations in the brain that we've already studied. So that's what I mean is this last unit is kind of the bookend for the semester. It's kind of cool because you should be able to track an awful lot with what we're talking about based upon what we've already covered. If you look at the intensity, we can vary our response based upon the intensity. Like, for example, how many fibers are sending the signal? How fast, the frequency at which the signal is being sent. The discrimination of which fibers are sending the signal, meaning you could actually have 100% of the fibers that go to that region of the brain, or you can have 60%. And your intensity would be directly proportional to the percentage of the number of fibers. And then lastly is how long does it last, the duration. Okay, so I want to do a little example. You need to pair up with your neighbor. Okay? What we're going to do is we're going to discriminate between a large receptive field and a small receptive field. And I'm going to try to go slowly because when I use numbers, it seems like it confuses people. Okay? Based on the last exam. So here we have one neuron with a large receptive field. You see how it's distributing its innervation pattern? Versus figure B on the right, there's three neurons with small receptive fields that span, let's say, a similar distance with these little calipers. Well, the one neuron with the large receptive field is exampled in areas that don't have a fine discrimination of touch. Okay? And so the information that is being sent to the brain, the somatosensory cortex, over this large receptive field on the left, is saying that all of that information is coming really from one spot. Versus, in contrast, three neurons with small receptive fields, the brain's basically saying, no, there's 2 or 3 or 4 different points in that same area that I'm getting information from. Okay? So what I want you to do is pair up. And you're going to use your fingers instead of calipers. Okay? And turn to your partner, and I want you to demonstrate this particular activity. Hey, Jordan, come up here. Okay? All right, turn around. So he's going to turn around, he's going to close his eyes because I don't want any other information coming in. Okay? And in a large receptive field area, I'm going to use 2 or 3 or 4 or 1 or 5 points of discrimination. Okay? You guys ready? And he's going to tell me how many they are. How many? 1. Okay, how about now? 2. Okay. How about now?
4.
Ooh, nicely done. Okay. Okay, so 1 out of 4. No, you're not done. Come back over here. Not done. All right, close your eyes and turn towards me. Okay, this is where it's more scary, right? I need your palm out. Both palms, okay? Same idea, right? So it was 1 out of 4 last time. Ready?
2. 1. 3.
Wow, 100%. Okay? All right, nicely done. Let's give a round of applause. Okay, can you guys do that? Do that with your partner and see. It's not going to be, perfect, but I think you'll be able to see the point. So take some time and see if you can replicate that. right? The person you're sitting next to. So how did it work? I mean, did it follow pretty much the general trend? So no, not at all. Someone's hypersensitive over here? Someone's very sensitive. Okay. So what's the point? The point is having small receptive fields in the hand. You also have small receptive fields in the face. We could do the same thing, but some people don't want to touch their face. Okay. But you have small receptive fields in area where you need a lot of discrimination about information. Okay, so you need to be able to determine if there are 2 or 3 or 4 unique places that are being triggered, okay, for a higher level of sensitivity. Now, in other places, like above the scapula, right, I mean, you need information that something's happening there, but it's not an area where maybe you're gripping a pencil, or using, needles, or a forceps, or you're, drawing, or you're trying to put contacts in your eye. Okay, those kinds of things don't happen in areas with large receptive fields. So the point is, the body's not going to spend biologic energy wiring everything exactly the same. It wouldn't make sense. Okay, so this is just another example of how the architecture or the structure influences the function or the physiology. Now, we talk about that all semester long. Here is another example. If we had a smaller instrument class of like 200 instead of 400, then maybe there'd be an essay question saying, identify examples throughout the semester where the structure has given rise to a very specific function. Make sense? And this would be one example. This would be a classic example. There's lots of others. We could talk about connective tissue. We could talk about irregular or regular connective tissue. Right? There's all sorts of muscle. The arrangement and the architecture of skeletal muscle is very specific. Right? So you see that theme throughout the entire semester. So if there's one thing that you take home from this semester that you remember, I hope it's that. Okay? Also that I had really good jokes. That's it. Okay. All right. Yeah, my kids do. My kids are funny. But, I help create that. So, I get both credit. Not as much credit as my wife. She had more work to do. But I was there. I was cheering, rooting. Standing by. My youngest daughter had a birthday last night, or yesterday. But we like to celebrate when they're born. And she was born at 8:34 in the evening. So all throughout dinner, she kept asking, am I born yet? Am I born yet? I'm like, no, not yet. You're not born yet. You should probably stop talking since you're not born yet. So, so she was born last night. 6 years ago. All right, so let's classify them by different categories. So we can talk about these receptors, and we can classify modality by origin of stimulus or by distribution. The distribution was the homework that you did. If you're going to characterize it by distribution alone, we're going backwards, I know, on the slide, but the general senses are all over the place. And the special senses are only found in the head. If you characterize them by stimulus, the type of stimulus, where it originates, if it's outside the body, it's considered an exteroreceptor. If it's inside the body, it's considered an interoreceptor. So, like things that detect pH changes or detecting it of the bloodstream. So that's an interoreceptor. An exteroreceptor would be things that are detecting external stimuli like a Meissner's corpuscle. And then a proprioceptor. This determines or gives you information about body positions or movements like the Golgi tendon or the muscle spindle. Up at the very top by modality, well, if it's detecting temperature, it's called a thermoreceptor. Light, a photoreceptor. Pain, a nociceptor. Chemicals, chemoreceptors. Or mechanical changes would be a mechanoreceptor. So if I was to identify a very specific type of receptor, okay, like a rod or a cone that's found in the eye, you would say that it is a photoreceptor by modality. It would be considered what? By stimulus. An exteroreceptor because it's detecting light that's coming from outside the body. And is it a, by distribution, general or special? Special. Okay, so don't be confused by an example that I would give that's very specific. These are broad classifications that obviously overlap, just like what I did with a rod or a cone. I know we haven't gotten to rods or cones, but we're going to. And so you can see how, depending upon how we decide to classify them, they may show up in a number of different buckets. Question? Good? Okay, if we look at organization, we can actually encapsulate these things or leave them unencapsulated. So if we decide to leave them unencapsulated, then they're not going to be quite as sensitive. And a lot of times they're just our free nerve endings. Okay? They're very basic in architecture, and this is highlighting this box, the top row. The top row are the unencapsulated nerve endings. Some examples are going to be things that detect light, touch, and texture. For example, like what happens within the hair. Right? The hair on your arms are connected to an unencapsulated nerve ending that gives you information about sensation on your arm. And as the hair kind of bends or deflects down, it triggers that unencapsulated nerve ending to give you information about what's going on in your outside environment. Now, if we want to, well, we'll look at these specifics. So free nerve endings, tactile discs, and hair receptors. Those are the three types of unencapsulated. The ones that are a little bit more interesting are the encapsulated type. The encapsulated type have more structure around them. So more biologic energy is spent making them, organizing them, putting them together for more specialized function. Okay, so the connective tissue is going to enclose it. Many of these that are encapsulated are in the category of mechanoreceptors. So you can see some examples here, like a tactile corpuscle, the muscle spindle that we looked at, the Golgi tendon, the lamellar corpuscle, the end bulbs, the bulbous corpuscle. Some other ones, well, tactile corpuscle is another name for Meissner's. So that should make sense of where this is. This is right at the junction between the epidermis and the dermis. The tactile corpuscle is another name for the Meissner's corpuscle. So you could write that in there for reference back to the beginning of the semester. The lamellar corpuscle, that's another name for the Pacinian corpuscle. This one right here. Okay? So there's 4 examples that we've already covered throughout the semester. If we look at these encapsulated ones, they're more sensitive. So things like the Meissner's corpuscle, this is going to be light, touch, and texture. The cross end bulb is found in mucous membranes, give you tactile information. Okay? The Pacinian or the lamellar corpuscle, deep pressure, found in the deeper dermis of the skin. It's also found in the periosteum of the bone. Okay, so you do actually have sensation around the bone that gives you information about what's happening stress-wise at the level of the bone. And then our bulbous, otherwise known as a Ruffinian corpuscle. This is more heavy touch, like joint positions and even stretching of the skin. Okay? Different modalities. That's all this is. Now, when we looked at the types of receptors and we categorized them by modality, we talked about nociceptors. Okay, so I want to talk about nociceptors, which are responsible for pain. So pain is something that is an interesting study, right? I mean, why does it exist? What's the point? Why does there have to be pain? Well, a lot of times it's giving us important information about what's going on around us. And that stimulus of pain that's caused by tissue injury or some harmful or noxious stimulation is letting your body know that it needs to get out of that situation. So usually it means that you're going to perform some sort of activity in response to that pain. So the last time you had a sprained ankle or a bum knee, okay, or you hurt your back, okay, some of you are like, well, these things don't happen. They will, trust me. Wait a decade, and then all of a sudden things start aching. You're like, what? Okay, I got to get a new mattress. Must be the mattress. Yeah, sure, of course, it's the and the water. Get new water and the mattress, and you'll be fine. You're just getting old. Right? So you think about the last time you had a sprained ankle. That's probably, or something was wrong with your knee. That's probably more relevant to you guys. And it hurt to walk on it. So what happens is you decide to limp, because when you don't stretch it, then it doesn't hurt. There's a perfect example of an evasive action, right? Or you go see your doctor and you're like, you know what, it really hurts when I go like this. And the doctor says, stop going like that. Okay? Just stop doing it. It won't hurt anymore. $25 copay, please. Okay? So there's an evasive action that your body naturally, or how many of you had a toothache, but you hate the dentist, right? So you chew on the other side. I've got 30 other teeth. I mean, at least. I'll just not use that one. So you chew on the other side, right? I noticed that with one of my kids a couple weeks ago. I was like, are you only chewing on the right side? I'm like, yeah, why? Because my left side hurts. I was like, that's probably not good. Well, I just thought I'd chew on the other side. Well, if it hurts, it's your body saying something's not right. Okay? Turns out we just needed to pull the tooth, but it was just loose. So this is important because it helps to protect us. Now, here's one of the complicating factors that you're going to see in patients, is in some patients, like what you're going to run across, in patients that have end-stage diabetes mellitus, that's non-managed, untreated, they end up getting vascular disease. And that vascular disease compromises blood flow to the distal extremities. And then that starves the nerves. And then the nerves of the distal extremities don't respond to pain. And this is called diabetic neuropathy. And so what happens is if they get a cut on the bottom of their foot, they can't even feel it. And that becomes infected. And that evasive action is gone. They don't even realize that they have a foot ulcer or a wound until it might be too late. And it's infected and it's not going to heal well. And in the worst case scenarios, we might have to actually amputate that region, whether it's a toe or a foot or even the lower limb. Okay? So this is just an example to prove to you that being able to detect pain is actually valuable to us as an organism. Okay, so how do we do that? Well, we use these nociceptors. And there's two main types. We have what we call fast pain and slow pain. Fast pain is an exam that only lasts 30 minutes. Slow pain is one that, I'm just kidding. You guys didn't get it, never mind. Fast pain travels via myelinated fibers. Okay, that should make sense. Right, so at about 12 to 30 meters per second, it's going to be perceived as sharp, localized, a stabbing pain. Whereas slow pain is more dull. A dull pain, like when you have an upset stomach or a bellyache, it's usually more of a dull pain, like just sort of like hurts. And it's actually very non-specific. It kind of hurts all over. But if you have more of a stabbing pain, like your appendix is about to rupture, you know exactly where that location is, right? Or if you just tore your ACL, that's not a dull pain. That's a very sharp type of pain, and you know exactly what's taken place. Toothaches are usually more dull, diffuse feeling. These guys are unmyelinated fibers, so they travel slower, 0.5 to 2 meters per second. If we characterize pain, if it's somatic pain, it's going to be coming from skin, muscles, or joints. If it's visceral pain, then it's coming from areas of the viscera, right? Chemical irritants would cause this. Poorly perfused tissue, or even stretch receptors that are happening within the gut. What happens? How does it trigger a pain response? Well, the tissues that are injured or are compromised, they release chemicals, neurotransmitters essentially. and they stimulate these nociceptors. So bradykinin is one of the most potent pain stimulants that we know of. Serves as a neurotransmitter and binds to these nociceptors. It makes us aware of the injury. Some other ones that are used, histamine, prostaglandin, and serotonin, also stimulate nociceptors. Now, what's interesting about our distribution of pain receptors throughout the body is that there's a lot of overlap. So, when we look at these projection pathways for pain with this overlap, many times, and we see this often happening within the abdominal area or the viscera, is we see what's called referred pain. Because we get overlap or convergence of these pain pathways, sometimes if the brain can't interpret where it's exactly coming from in the map. Remember the homunculus in the brain? Where it's in the somatosensory cortex and the motor cortex on the anterior portion, but in the posterior portion, there's a map of the body. And the map of the body, you know, had a really large hand, a big face, right? Smaller shoulder. Well, the area that designates the viscera is a smaller area, and so if you're getting information coming from the viscera, you're unlikely to say, well, you know what, my gallbladder is, it's actually my common bile duct is a little achy right now. Okay, it's just sort of like, oh, it hurts. Okay, because the brain has to interpret this signal like a wiring pathway, and it has to be able to try to distinguish the source. If it can't distinguish the source, then it assumes that it's coming from a more superficial location most of the time. Sometimes it can be felt at the level of the skin. Right? You see this in pediatric medicine when a kid has a stomach ache and the pediatrician says, where does it hurt? Right here. All right here. Right? This all hurts. You're like, wow, that's broad. Okay? Can you be more specific? Yeah, like here, and here, and here, and here, and here, right? And the kid is just sort of doing this. It's just, the child is actually just telling the pediatrician exactly what the brain is interpreting. Now, as adults, we understand, you know what, I can't really tell you where, it just kind of hurts all over in my abdomen area, right? Because we actually have a little bit broader vocabulary. But we're saying kind of the same thing. So, for example, you see this in heart attack patients. Heart pain. Heart pain is felt, you ever wondered why it shoots down the left arm and that's usually like a warning sign that someone's having a heart attack? Because the nociceptors that serve the heart itself are sent via segments T1 through T5. So if you look at this referred pain diagram, if you look at the left figure, you can appreciate that this region here, from T1 to T5, not only serves the left upper thoracic cavity, but it also has shared pathways to the left arm. And so that's that distribution of shooting pain down the left arm when there's actually chest pain. Make sense? Okay, so this is visceral pain misinterpreted as coming from a more superficial location. All right, some other interesting facts about pain is that the damaged tissue itself releases the signal to tell you that there's pain. So the tissue secrete, we said, bradykinin, the most potent. They secrete histamine, prostaglandin, serotonin's another one. All of those could go in this blank. And that stimulates the nociceptors. Those are pain receptors. We said that the first stabbing type of pain is called fast, and our more slow response via unmyelinated fibers is our second type of pain. So what is the connection to Icy Hot? Why is there an Icy Hot image on this slide? Any ideas?
Does that have to do with the menthol, maybe blocking sort of pain receptor below?
It doesn't necessarily block, but you're on the right track. So the active ingredient in menthol is methylsalicylate. Yep. It does create it's not really a referred pain, but it is a masking type of activity. So what ends up happening is the pain pathways that come to the brain, they also actually share a common pathway with temperature sensation. So when you put on an Icy Hot or a Tiger Balm, and it has this methyl salicylate in it, or menthol, then the temperature signal, you put on a lot, right? You just like lather it on, and people are like, whew, man, you smell good, right? So you put it on, and in like 5 seconds, it's like your skin's on fire, right? Well, that is such a large signal, and the sensations for temperature travel much faster than pain, and so that pathway is being overrun with temperature sensation, and so you don't get the signals about pain until it wears off, and then you got to lather up again. Okay? So this is an old piece of information. I mean, Eastern medicine has been using methyl salicylate for centuries. Okay, Icy Hot wasn't invented by, the NBA. It's been around for a long time. Does it work? Absolutely. But it works just like Tylenol or aspirin or ibuprofen in the sense of an analgesic. It is a pain-relieving substance. Does it fix anything? No, not typically. If you have a headache and you take a pain reliever, you haven't fixed anything, just so you know. The reason you had a headache is probably still there. You just masked the pain. So this is another part of the lecture where as we move on and you guys become healthcare providers, we live in a society now where something's wrong, fix it. Right? I have a cold, give me a pill. I don't feel good, give me a solution. Well, when we're prescribing pain medication, we have to be careful because if you treat the pain and mask it, you may just be turning off the signal that's telling you something's actually wrong. Right? It's like, how many of you have any experience with an alarm system, like a house alarm system or a security system of some sort? So it's like the siren's not on, but the light's blinking, right? And you just decide that you're going to put a piece of tape over the light to hide the blinking because it is annoying and it keeps you up at night. Right? Now, have you fixed the problem? Of course. It's not keeping you up at night. But what's causing the alarm to trigger is still there. Okay? All right, so interesting fact about pain. Now, looking at our pathways of pain, as we wrap up this particular lecture and move on into special senses, I want to show you this pathway and talk about how things work, because we actually have natural pain analgesics in our body. So it's not all bad. So I'm going to talk out of the other side of my mouth for a moment. The body's actually wired to mask pain so that you can actually do certain things in certain circumstances. So is Keller advocating that we shouldn't be prescribing any pain medication to patients? No, that's not what I'm saying. But if you're having chronic headaches like every day, and it's always at 3 p.m., which is right about now, okay? I hope I'm not the cause, but there may be a reason that you're having, well, I don't lecture every day, so it can't be just me, okay? So the body does do this, and so I'm saying if it's routine, it may not be a good thing. But obviously, there are a lot of circumstances where we want to mask pain, surgery, okay, end of life, recovery, so that you can make the patient more comfortable. But again, I don't think anybody would advocate that the chronic use of pain analgesics is a good idea. If you think that's the case, just pick up like the National Enquirer or the Globe, and you'll see how big of a problem that is in our country. Okay, the overuse of analgesics, whether they're prescription or non-prescription. Okay? All right, so let's look at what's going on. You can see this pathway loop. Here is a flame and a finger, and obviously a nociceptor is being triggered. And the difference in the intensity of the pain is the frequency, how quickly over time it fires, and or the number of nociceptors that fire. So if your hand was over this, and this was an open flame, you'd have more nociceptors per unit area, right? And the hand, we already said, is a small receptive field, so it's extremely sensitive. In fact, it would be more likely you're going to detect it more quickly with your hand than you would, like, how's the water? Is it warm enough? And you're trying to get your scapula in there. Okay, usually you put your toe in or you put your hand down, right? You don't like put your thigh in, like, that's a little cold, right? Because you're using small receptive fields. The people up front are like really going to scoot back, like it's really animated today. Well, if we get the signal coming through, you can see that substance P, this is a neurotransmitter that helps to transmit this signal. Substance P for substance pain. That's the neurotransmitter of this pathway. This is the green dots right here that trigger these secondary tracts. This is the spinal thalamic tract. It goes via the spine to the thalamus. That's why we call it spinal thalamic. And then at the level of the thalamus, you head into the cerebral cortex, where the cerebral cortex tells you, that's my left finger, or my left thigh in the water. Not sure why we didn't use the finger, right? So then the brain interprets, like, you probably look really strange right now, or you could have just put your finger in the water. So that's when that happens, but it's too late, it's already happened. And now you're sending signals down via the midbrain. The hypothalamus obviously sends some information, like, should I have an emotion about this, right? Is this awkward? Am I thirsty at the moment, right? It's all this information that the hypothalamus would send. It goes through the medulla oblongata. Now it comes back down. This is the dorsal horn, right? And then it comes in, and it's going to come out motor-wise. It's going to come out dorsal or anterior root? Anterior if it's motor. But right now what it's doing from this dorsal side is it's sending a signal onto this nociceptor. And you can actually block this signal with enkephalins, otherwise known as endorphins. These are endogenous opioids. Right? These are endogenous or naturally occurring pain relievers. And so it's this way that we can physiologically fight through the pain and continue to do an activity with endogenous opioids. Right? So an enkephalin is 200 times as potent as opium. So we're like, yeah, I've heard of that, but it's 200 times as more potent than heroin or morphine. Okay, we don't use a lot of opium medically in this country, but we don't use a lot of heroin medically, but we do use morphine. Okay? In fact, we'll use morphine to get a heroin addict off of heroin. Okay? So enkephalins are 200 times more effective or more potent than these substances that you've heard about. And we make them ourselves. So that's the other side of the argument. Is, okay, I think we overprescribe pain medication, yes. But yet at the same time, the body has natural times when it needs it and it will release it. You'll release lots of endorphins during very stressful circumstances. Right? You've heard these crazy stories of like the 97-pound mom whose baby carriage was ran over by a car, and she goes and lifts the car up off the baby and pulls the infant out, and all the onlookers are like, how did that happen, right? And then S.H.I.E.L.D. flies in, and then they take her off. But this is enkephalins, right? This is this endorphin effect that happens. This is the same thing that happens. How many of you have experienced sort of a exercise high, if you will? They call it runner's high if you're a runner. But it's not just runners that get it. Okay, that's exactly what happens is your body starts to release these enkephalins, saying, okay, I guess he's not going to stop running. So let's just help out a little bit, try to get through. It must be a really big bear that's been chasing us for 25 miles. Really surprised that there isn't any local law enforcement that can help out here. So then your body just releases enkephalins. Okay? So this is the natural process. They're secreted by the pituitary. And what they do is they block these first-order neurons right here. They block these first-order neurons from ever sending the substance P. So the nociceptors are still getting the signal of like bradykinin, and they're still trying to fire. But that first order neuron never releases substance P, which is the neurotransmitter, to the next signal, so it never reaches the brain. So you still are detecting pain, you just are not allowing it to go to the brain. Okay? It also means that the pain is still there, right? It's just you're deciding to ignore it. It's like putting a piece of tape over that alarm light.
So this part of the, like, you'll feel it in the morning or whatever, like after somebody gets in a car accident, like they don't feel the direct pain that day, they feel it the next day.
Yeah, so some of you have experienced that. You've been in a car accident, okay, and you're injured, okay, and you're shuttled to the hospital, and usually you'll feel stuff even in a few hours. You know, there have been patients that have broken limbs severely, and they end up in the hospital, and the pain doesn't really set in for about an hour or two later, after all of the endorphins have worn off. That's your body's way, and it's a protective mechanism, because if that was, for example, the bear caught you and you somehow survived, you need to be able to get away. And if you're so focused on not being able to contract your muscles, you're done. So it is a natural protection to allow you to escape until you can actually be safe. Okay? All right, questions? Pain is a fascinating topic. We could spend half a semester on pain, but we don't have that time. Yeah.
You said that for that nociceptor in the finger to sense pain, is that like an example of the temporal summation from earlier in the semester?
Oh, temporal summation. That's a good question. Right here? Yeah, so temporal summation would be if the frequency was firing quickly. It could be spatial if it was the whole hand, right? And then it would be nociceptors from many different areas. Yep, absolutely.
So as the flame got closer, that temporal summation would happen faster?
Correct. Yep, you got it. You got it. But it also helps with that receptive field thing. That's why, you know, in our world and our environment, you watch children do this all the time. Like, don't touch that. And you're like, right? But that's their way of determining what is it. You know, they don't like, put their shoulder on it like, oh, I wonder if it's sharp, right? They always do this. So we know that our receptive field is pretty dialed in right here. Okay? And we use it.